Hello and welcome to the Motivational Midwife. I'm Lynn Jones and today we're going to look at antepartum hemorrhage. So we're looking at antepartum hemorrhage, and as always we'll start with what is it. So RCOG define this as bleeding from the genital tract or into the genital tract after 24 weeks. So 24 weeks of pregnancy obviously is when the baby is viable, then it's an antepartum hemorrhage. Prior to this it'll be a threatened miscarriage. For us in maternity, the most important ones are placenta previa and placental abruption, but they're not the ones that you will see most frequently. And so recognising it, from an emergency perspective, if someone's coming in with catastrophic bleeding, the treatment's pretty much going to be the same for all of them. They're going to end up in theatre. But it is useful for you to be able to differentiate between whether you're looking at an abruption, a previa, a uterine rupture, or even a vasoprevia. So in this session, we're going to go through how you can tell the difference between those. So placenta previa and placenta accreta, this is where the placenta is partly or wholly implanted in that lower segment of the uterus. So it's in that lower bit of the uterus. And an accreta is where the placenta is now morbidly adherent. You're more likely to get those morbidly adherent placentas, certainly on previous caesarean sections or people who've had uterine surgery. And previas can be divided up into, years ago we used to have grade 1, 2, 3 and 4. Now we have major or minor. So the major one's completely covering the internal os. So there's no way that baby is going to deliver vaginally. These women will have an elective caesarean. And often at the end of a list, because the risk of hemorrhage is really quite severe for these ladies. And then you've got the minor ones where the leading edge is in the lower segment, but it's not quite covering the os, or initially in pregnancy it may be on these are the ones that women are deemed to have a low-lying placenta, and they'll often have scans later in the pregnancy to see if it's actually far enough away from the internal os to facilitate a vaginal birth. And if memory serves, I think it's 2.5 centimeters. I can't remember off the top of my head what it is. It needs to be away from the cervix to really be safe for them to have a vaginal birth. When you have got a low-lying placenta, it is worth bearing in mind, if you think of your physiology and your living ligatures, they are mostly formed in the upper part of the uterus, in that fundal area where the myometrium is thicker. So if you have a placenta in the lower segment, a low-lying placenta, it's always worth having in the back of your head that this lady is likely to have a heavier loss postnatally, and she may well have a heavier loss at delivery because there isn't the uterus is thinner in the lower segment, and therefore there is less ability for those living ligatures to form. So they often present with recurrent, fresh, painless bleeding. Okay, there is no abdominal pain. When you palpate the uterus, it's soft. Presenting part might be high because you've obviously got a placenta in the way, so that it can't really engage down. And in the most current MBRRACE report, 3 women died as a result of hemorrhage associated with placenta previa or accreta. So placental abruption is where the placenta has either partly or completely come away from the uterine wall, again after the 24th week of pregnancy and prior to the delivery of the baby. And so this would really present itself with PV bleeding, and it could be revealed, so it's obvious, you can see there's quite a lot of bleeding coming out vaginally, or it could be concealed, so it's actually collecting behind the placenta, and there's not very much vaginally that you can see, or it's mixed, it's a bit of both. When you palpate the uterus, it is very hard, and this is because the blood is being forced back into that myometrium, into that muscle layer, and so it makes the uterus very congested and very hard. It's extraordinarily painful for these women, so the chances are they're not going to want you to touch them at all. There will be a degree of hypovolemic shock there as well, because if you think the blood flow through the placental site is 500 to 800 mils a minute, so if that is abrupting, there's a considerable amount of blood loss quite rapidly. And 3 women died as a result of hemorrhage associated with placental abruption in the latest report. So uterine rupture, now this is, although it can happen spontaneously in a primate, it's usually associated with someone who has had uterine surgery before, so your previous caesarean section, so they've already got a scar on the uterus, and it ruptures. Essentially, it either completely ruptures, so goes right through everything, or partially ruptures, so it's starting to go, but you've still got the uterine serosa is still intact. It's documented that, you know, there could be no pain associated with this, but to be fair, I've never known anybody have no pain with a uterine rupture. It's not something you see a lot of, but it is certainly, I've noticed a bit of an increase over the last sort of maybe 10 years. There's been more of it than before, and that's probably due to the fact that we've had an increasing caesarean section rate. So severe abdominal pain, and these women will get breakthrough pain. So even if they've got an epidural on board, you should really be assessing whether they've got any tenderness or pain, particularly over the scar area, because that will break through an epidural. Signs of hypovolemic shock as well. If you palpate, then fetal parts are very easy to palpate because obviously they've come out of the uterus. For intrapartum, you might get PV bleeding and classically hematuria. So if she has a catheter in, you would notice hematuria. So these women with epidurals that have got catheters in situ, closely watch the colour of that urine. If they go to pass urine, they haven't got a catheter in, then you should be testing and having a look at the urine they're passing to make sure there is no hematuria in it. And that's blood in the urine. The uterus feels soft on palpation, and because you've disrupted that uterine muscle, then contractions often stop. And classically, it will be associated with a fetal bradycardia, and that's often the first thing that alerts you to the fact that there's a rupture, is that there's a deep bradycardia. Finding stats around how much uterine rupture actually occurs is quite tricky. It's not really mentioned particularly in any of the MBRRACE reports, but the World Health Organization associate, you know, almost 1% mortality in high income countries, and a much greater percentage, up to maybe 28% in low income countries. So it is quite a problem. Now, vasoprevia we won't cover particularly in this session, but it is something to be aware of. And these women often have small PV bleeding, often with the rupture of membranes, but you will get a fetal bradycardia because the blood that's escaping is fetal blood, it's not maternal blood. So the mother will have no ill effects, she won't show any signs of hypovolemic shock. This is the baby that is running into difficulty here. So when we're thinking of risk factors, so anybody with a previous history of certainly placenta previa or uterine rupture, any of those are more likely to have it again. And obviously, if they've had uterine surgery before or previous caesarean section, it increases their risks of placenta previa, because we've already said that if you've had previous surgery, you're more likely to have a abnormally situated placenta or an invasive placenta. It will become really quite adherent. Assisted conceptions put you more at risk of placenta previa, often because there is scarring within the uterus, and multiparity, again, because there's placentas do quite like nice fresh spots to embed themselves on. So the more babies that people have had, the more likely they are to have scar tissue within the uterus. Multiple pregnancies, again, if you've got more than one baby in there, you're likely to have quite a large placental site or more than one placenta, and therefore it will encroach on that lower segment. Smoking, again, the effects it has on placentas. Increasing maternal age seems to increase the risk of all of them, and the exact reasons for why are not totally clear. Previous terminations, again, because you're likely to have scarring, and greater than 42 weeks, bigger babies on board. Cocaine use, again, it seems to affect the blood vessels within the placenta, as does hypertension and preeclampsia. Trauma is a fairly straightforward one. Obviously, if there's been trauma to the abdomen in a road traffic accident or domestic violence, then abruption is quite likely. Induction of labour, because we are potentially hyperstimulating that labour, that uterus, so it may well put them certainly at risk of abruption or rupture. Polyhydramnios, it's not polyhydramnios itself that is the risk factor, but actually when the membranes rupture, because you have that sudden change in pressure within the uterus, and so potentially it can cause an abruption as well, certainly predisposed to an abruption, which is why we're very careful with polyhydramnios to do what's called a controlled rupture of membrane, so a controlled ARM. Growth retarded babies, again, because there's often other things going on with that, so preeclampsia, so the placenta is usually not functioning as well as it could do. Low BMI, similar reasons. Infection, again, similar reasons, and prolonged rupture of membrane, and it looks like I've put assisted conception on there twice, and previous abruptions again, and be mindful of anyone who has had first trimester bleeding, because that does put them slightly more at risk of placental abruption. So just again, have it in the back of your mind when you're reviewing people's notes if they've had any bleeding in early pregnancy. So in a nutshell, then, if we've got bleeding from an abruption, it could be revealed, concealed, or mixed. The abdomen is going to be extremely painful to palpate, if they let you palpate it at all. If you can palpate it, it will feel very hard, very woody. You will be very difficult to actually feel any fetal parts. Placenta previa, bright red, fresh bleeding, painless, and the uterus is soft on palpation, and your presenting part is usually high. And uterine rupture, often minimal vaginal bleeding, but the pain does vary from no pain at all to what's termed exquisite pain or tenderness. So that's really excruciating pain. And the abdomen, uterus on palpation will be soft. There may be no contractions anymore, and you can feel fetal parts really very easily. And it will often be associated with a bradycardia. So how are we going to actually manage these? So all of them need a multidisciplinary team approach. Okay, so good teamwork, good communication is key. Pretty much every MBRRACE report highlights this time after time after time, that most of the where we fall down within the system is that we don't work well as a team, or we don't communicate well as a team. So we're looking at the management of this. So in all of them, and for this, we're not looking at those bleeds that come in and are conservatively managed. We're looking at major bleeds that need dealing with now. And there will be signs of hypovolemic shock. Okay, so we will look at antepartum hemorrhage that is conservatively managed in another session, but in this session we're looking specifically at the emergency. So there will be signs and symptoms of hypovolemic shock. We need to stabilise her and get her to theatre, essentially. So we do want our anaesthetist there fairly quickly. And generally they are the experts in airway management and fluid balance. So really we're looking at them managing the airway. We want some facial oxygen on this lady. So it's your job to get that on there until they arrive and take over the airway management. But facial oxygen, 10 to 15 litres through a non-rebreathe mask. So we want that high flow oxygen to support her cardiovascular system because she is in hypovolemic shock. So there is a loss of circulating volume. Respiration rate is likely to be rising because she is trying to compensate for losing blood and oxygen sats. Without the facial oxygen, they are likely to be below 95%, but hopefully with the facial oxygen, we're managing to keep them above that. Heart rate is going to increase as she is trying to compensate for that loss of circulating volume, and eventually the blood pressure will drop, but it's likely to stay stable for a little while, not necessarily very long if she's really pumping it out. And capillary refill is likely to take longer because she is losing circulating volume. Okay, so document these. You want to take these observations fairly frequently. So depending on the situation, could be 5-minutely, 10-minutely, 15-minutely. And document them on your meows chart or your high dependency chart so you can see a pictorial representation of how her condition is changing. Because any one set of observations in isolation is not necessarily that useful. You need to really look at the picture. And if you have computerized systems, as we do where I work, you really need to go into the screen that has the meows chart on so you can see the trends. You can see whether her pulse is slowly rising more or dropping more. Even generally, not in an emergency situation, you need to go back and look at those screens. And this is something I feel that when we moved to a more computerized documentation system, I feel that we've perhaps lost that. We don't always think to go in and look at the screen in its entirety. We certainly data input, but if the data input is no good if you don't actually look at the emerging picture. And of course on a paper chart you can see that quite easily. So think about your delegation. Remember under your midwives, the code of conduct and your midwives proficiencies, you are accountable. You need to think about who can do what. Don't delegate someone something to do that they don't have the skills for. So someone will need to get some wide bore cannulas in because we've already dealt with the airway at the ABC bit, but we need to get some cannulas in. We need to get fluids up and we need to get bloods taken. So once you've got your 2 wide bore cannulas in, and we need wide bore in maternity. Remember, as I've said, the blood flow through that placental site is 500 to 800 mils a minute. So we need wide bore cannulas, big fat grey cannulas, to really get fluid in rapidly. A little tiny pink one is not going to do it. You're not going to be able to get fluid in quickly enough to make a difference. So a full raft of bloods taken, and then put your crystalloids up. Remember, you can put the first litre up under your midwives exemptions, but you need to make sure that everything is documented on the drug chart and signed for by your obstetric colleagues. You need a maximum of 3 litres of clear fluid before you really should be considering blood, because remember, clear fluid has no oxygen carrying capacity. So if she's bleeding so heavily that she's needing 3 litres of fluid, she is losing a considerable amount of hemoglobin and oxygen carrying capacity, so blood should be considered. And as the midwife, if you are putting up the second or third bag, you really need to make the anaesthetist aware and ask, does he want the blood? If the cross-match blood is not ready, then O negative blood should be considered. Okay, we've got cannulas in, bloods out, fluids up. We need to monitor her urine output. Her fluid balance needs to be monitored very, very carefully. So catheter in with an Owly bag, and as per most emergencies that we need a catheter for, 0.5 mil per kilo per hour. And it is important that we actually do that accurately, because the urine output on somebody who's got a BMI of 17 expected urine output is going to be very different to the expected urine output on someone who's got a BMI of 40. So although we usually think of sort of 25-30 mils an hour as an approximate, you really should be giving individualized care, and you should be working it out for that individual woman, and monitor your input and output very closely on the fluid balance chart, and keep your anaesthetist informed of any concerns you have, because the danger is that we could fluid overload as well if we're not careful once we get a stable. So if it's possible to monitor the fetus, it will depend on your clinical picture, and again, management does depend on clinical picture. As I've said, we're not going to really talk about those antepartum hemorrhages that come in and settle, and then we just conservatively manage it. These women we're talking about are in and going straight to theatre. So it may be that you don't have time to do a proper full CTG. You may just have time to listen with a sonic aid. The registrar may be able to do an ultrasound. If you are having a more conservative management picture, then you have time to think about those 4 bests for delivery. So have you got time to stabilize? Maybe give her steroids. If it's a preterm baby, what time of day is it? We don't really want to be doing emergency cesarean sections in the middle of the night. It's much better to do them in the daytime when you've got more staff, more expertise about more facilities generally. The best place, are we in the appropriate place? Is she a little standalone unit? Do we need to get her transferred to a consultant-led unit where they have theatres, intensive cares, high-level special care facilities? And also the route, is it possible to do a vaginal delivery, or do we need to do a cesarean section? And our senior staff need to be about. They are key and essential. But those 4 bests are essentially around antepartum hemorrhages that are conservatively managed. In an emergency situation, these women will be going straight to theatre. Okay, so when you need to be preparing them both physically and psychologically for going straight to theatre. So you still have to, although this is emergency, you still have your pre-op checklist to do. You still need to make sure that she's got proper name bands on that are correct, that she's got a gown on, that she is consented. Now, in an emergency, this tends to be implied or verbal because you are acting in her best interests. And the anaesthetist will give pre-operative drugs in theatre. And these could be, certainly historically, it was ranitidine, 50 milligrams IV, which helps sort of slow the acid production down. And these drugs are given to minimise the risks of something called Mendelssohn syndrome, where patients generally, not just pregnant women, would vomit and then aspirate that into their lungs. And that acid in your lungs is really not very good for your lungs. So these are, it's a very rare thing to happen, but it does happen. So these are given to minimize the risks of that happening. So ranitidine went out of favor recently for a little while, but it is still in use. Omeprazole seems to have taken its place in a lot of units, and omeprazole is fine if you are preempting that you might have a cesarean section, but in an emergency they don't work quite as quickly in slowing that acid production, which is why several drugs are given. Metoclopramide, or Maxilon as it's often known as, ranitidine is also known as Zantac, stimulates the gastric emptying. So actually it stimulates what's already in the stomach to sort of move along the bus a bit quicker. And then sodium citrate is a little drink. It smells quite nice, but tastes vile. And that neutralizes any acid in the stomach. And that tends to be the thing that will work the quickest. And you may not be aware of it even being given because, as I say, these things are given by the anaesthetist, usually in theatre. So one drug will slow acid production in the first place. One drug will neutralize the acid that's already in the stomach, and one drug will help the stomach empty quicker. And all of those things combined help minimize the risks of Mendelssohn's. Okay, so thinking as well about who you need there for that cesarean section outside of the team that are actually doing the cesarean section, you want some senior paediatricians there. Your poor SHO doesn't really want to be there on his own for this baby, because if it is born alive, it's going to be born in very poor condition and probably needs some extensive resuscitation. So really make sure that you've got a registrar en route as well to support the SHO, or it may well be that the registrar's there and needs the consultant to support them. Take cord bloods, not just for CLIHA, but also for cord gases. It is important to see just how compromised this baby has been, and think about your documentation, careful documentation of exactly what's happened. Within the emergency, you will have delegated someone to scribe for you, so you need to transcribe those scribes' notes into the maternal records, and whatever your documentation is around the baby needs to go in the baby records. And then make sure you've got a succinct and accurate SBAR handover to give the next midwife taking over care. So thinking of some possible consequences, well, these will be anything that are to do with major hemorrhage. Okay, so the most common one that we are likely to come across is that they will be anemic. So you need to make sure that you've done a full blood count, normally 6 hours post op. They check the HB, and it may well be that she will need a blood transfusion. So you have to think about all the safety issues around transfusing blood, and we will do that in another session. But at the very least, she's probably going to need iron supplementation. So you'll need to think about getting that prescribed for her and making sure that she's got TTOs or tablets to take away, or tablets to take out, I think is the proper. I've forgotten what I was going to say there. But yeah, so TTOs prescribed and ready for when she is fit for discharge. Infection obviously is a big risk because she's likely to have had a cesarean section, so any surgery puts people at risk of infection. You've opened the skin, and the skin is our main barrier to infection. Antepartum hemorrhage will predispose women to postpartum hemorrhage, so careful observation of her lochia and the amount, and that she's not passing any clots, that it's not offensive, and also having that discussion with her about her PV loss and what is normal and what is not normal, so that she knows when to, because even after these emergencies, the women respond very well, and we are discharging them home relatively quickly. So women need to be educated as to what is normal and what is not normal, and when they need to seek help, particularly in this day and age when really they're getting very, very few postnatal visits, and COVID has really just impacted on that even more. Any sort of major hemorrhage will predispose women to venous thromboembolism and DIC. And obviously, if we've had tissue hypoperfusion as a result of that hemorrhage for any length of time, we're going to get organ dysfunction or organ failure. And as we've said previously, the first one that usually shows sign of hypoperfusion is the kidneys. So careful fluid balance, watching that her kidneys are functioning properly, so is her urine output normal. Remember, in those first few days post-delivery, we're expecting a diuresis, we're expecting her to pass a lot more urine because her body is getting rid of the extra fluid it put on in pregnancy. So even despite the hemorrhage, we're still expecting reasonable urine output. Mendelssohn syndrome we have discussed, and the complications of cesarean section. So we've got pain, we've got reduced mobility, which again will increase her risks of VTE. You've got difficulty potentially in actually caring for the baby initially because she is immobile, she's in pain. As we've seen from the MBRRACE report, women do die of complications of antepartum hemorrhage. But fortunately, I've never come across one yet. It's never been in my career, and I hope to goodness you never do either, but it does happen. They could be quite traumatized by this, so think about, they will need debriefing, but do they need more than debriefing? So the doctors, you need to make sure that the doctors have come back and spoke to both the woman and her partner, whoever that was with her, because it may not have been her the baby's father that's with her. You know, she may have chosen to have a different relative with her, and it's important that the debrief is for both of those individuals, because partners, whoever they are, birthing partners, can also be in some ways more traumatized by the events that are going on. So it's important that we make sure we've debriefed and, if appropriate, refer for counselling. Any sort of hemorrhage is going to impact on lactation. So think about how you're going to support her with feeding. Do you need to get hand expressing going? Do you need to get a pump going? Is she separated from the baby? Because I say, if this baby has survived, and certainly with abruption, it is extremely unlikely that those babies will survive. It is likely to be extremely compromised. So it's likely to be in special care for some considerable time. So think about how you're going to facilitate visiting and bonding with that baby, and as I said, supporting that partner as well. For the baby, as I've said, with all of these, but particularly abruption, death, it really is a strong possibility. We have our 5 H's of resuscitation, which, as I say, I've been through in the NLS video, but it's your hypothermia, hypoglycemia, hydration, a delay in going home, and hypoxia. This may be a very preterm baby, so you may have all the complications associated with prematurity. It could be a small for gestational age or growth restricted baby. Admission to NICU has its associated risks, neck being one of them, but there's a lot more invasive procedures that happen to these little babies. So we need to be mindful, and doubly mindful with COVID, of infection. And there we have it, antepartum hemorrhage in a nutshell. I hope you found it useful. If you haven't subscribed to the channel already, please do. We also have a Facebook page, and I look forward to seeing you next time.